We practice in an era of unprecedented neurological advancement. I mean, we have targeted monoclonal antibodies, advanced neuroimaging techniques like MRI and CT, and rapidly evolving genetic therapies.
Exactly. The field is moving incredibly fast.
It really is. Yet, when we look at our daily prescribing habits for one of our most common clinical challenges, which is excessive daytime sleepiness, we find this fascinating paradox.
We are essentially relying on a foundational evidence base that is older than many of the medical residents currently walking our hospital halls.
Precisely. Welcome to the Weekly Neurology Deep Dive, produced by Amer Gavanini. Please note that this deep dive is strictly for educational purposes and has absolutely no commercial goals. It is simply a comprehensive summary of the data, and you are highly recommended to read the full paper we are discussing today.
Absolutely. Always read the full paper.
So, today we are examining a paper titled An Updated Systematic Review and Meta-Analysis of Modafinil for Excessive Daytime Sleepiness in Narcolepsy, authored by Govind Singh Mann and colleagues. To respect your busy schedule in the clinic, we will start with the bottom line. What is the immediate practical takeaway from this paper?
Well, the practical summary is that modafinil remains a highly effective first-line treatment for excessive daytime sleepiness in adult narcolepsy. It improves objective wakefulness by roughly 4 minutes and subjective sleepiness by about 3 points on standard clinical scales.
Which is significant for daily functioning.
Indeed. Furthermore, splitting higher doses, such as 400 or 600 milligrams, proves vastly superior for late-day symptom control compared to standard morning dosing.
But there is a catch regarding the data itself, correct?
There is a massive catch. A startling lack of modern randomized controlled trials means we are heavily reliant on short-term efficacy data from the late 1990s and early 2000s. Long-term safety data still requires larger prospective trials to solidify our clinical confidence.
That final point regarding the vintage nature of the clinical trials is striking. We are discussing a medication that neurologists prescribe almost every single day.
Every single day in sleep medicine, definitely.
And yet it rests on an aging foundation of randomized data. Let us look at the methodology to understand how the authors arrived at this conclusion.
Sure.
The authors screened over 4,000 papers up to August of the year 2025. They were strictly looking for clinical trials and cohort studies.
And they included 9 studies in the systematic review and 5 in the meta-analysis, which encompasses nearly 1,000 adult patients.
But the shocking revelation from their search, and this is what really stood out to me, is that they identified absolutely 0 eligible randomized controlled trials published in the past decade.
0. The absolute silence in the recent literature regarding a cornerstone therapy is a profound observation.
I mean, it feels like a massive blind spot in modern neurology.
It does. When you screen over 4,000 records and cannot find a single eligible modern trial, it forces a reevaluation of the landscape of sleep medicine research. We're relying heavily on legacy data to guide contemporary clinical decisions.
I often compare prescribing modafinil to driving a car where the crash tests have not been updated since the late 90s.
That is a very accurate analogy.
If we are prescribing this medication so frequently, why has clinical trial activity for modafinil completely stagnated? And how does this impact our confidence in long-term safety?
Well, this phenomenon reflects a concept we can sort of call therapeutic complacency.
Therapeutic complacency, I like that term.
You know, the lack of new randomized controlled trials does not mean the medication lacks efficacy. Rather, modafinil simply became the universally accepted standard of care.
It became the baseline.
Exactly. It became the benchmark against which all other therapeutics are measured. And once it achieved that entrenched status, research dollars and clinical trial infrastructure predictably shifted.
Shifted toward newer, novel, wake-promoting agents, I assume.
Precisely. The pharmaceutical industry moved on to investigate newer dopamine transporter inhibitors and other novel targets. However, this shift highlights a critical gap in our evidence base.
Because we are missing the modern comparison.
We are. We still lack robust, modern, head-to-head comparisons between modafinil and these newer agents using contemporary trial designs. And crucially, we're missing long-term randomized safety data.
So we only have cohort studies and short-term efficacy data to rely upon.
Exactly.
Knowing that the data is older, our discussion must naturally transition to what exactly those legacy trials measured and proved regarding efficacy.
The meta-analysis focused on 2 primary metrics that we use constantly in practice.
The maintenance of wakefulness test and the Epworth sleepiness scale.
Yes, those 2.
So for the maintenance of wakefulness test, which involved about 750 patients across the analyzed studies, there was a statistically significant mean increase of about 4 minutes in wakefulness compared to a placebo.
And then for the Epworth Sleepiness Scale, involving about 690 patients, there was a statistically significant mean reduction of about 3 points compared to a placebo.
Those two metrics provide a pretty comprehensive picture, do they not?
They do, because they seamlessly evaluate both objective laboratory measurements and the subjective functional experience of the patient in their daily life scenarios.
Let us unpack this. I find it fascinating that the maintenance of wakefulness test only showed a 4-minute improvement.
It does sound small at first glance.
I mean, to my patients, 4 extra minutes of wakefulness sounds incredibly trivial, like the time it takes to brew a cup of coffee.
Sure, isolated like that, it sounds minor.
But I always remind them that we all know the maintenance of wakefulness test is a torturous environment for these patients. Sitting still, in a dim, quiet room.
It is designed to induce sleep.
Exactly. So seeing a statistically significant 4-minute bump in that specific low-stimulus setting is what gives us the confidence to extrapolate to something like, well, highway driving. Does the paper's data support that specific clinical translation?
The data strongly supports that translation, absolutely. The context of the test dictates the clinical value of the result.
Because it removes distractions?
Precisely. The laboratory setting for the maintenance of wakefulness test strips away all the behavioral compensatory mechanisms a patient typically uses in daily life to stay alert.
Like pacing around or drinking water.
Exactly. So if the medication can fortify the patient's wakefulness in that sterile, challenging environment by a statistically significant 4 minutes,
Yeah.
it acts as a robust neurochemical foundation for complex daytime functioning.
It gives them a crucial buffer.
Indeed. A 4-minute delay in falling asleep under those extreme soporific conditions translates to vastly improved alertness in stimulating real-world environments.
Which means they can keep their jobs.
Yes, in clinical practice, an objective improvement of that magnitude directly correlates with improved daily productivity and a significantly reduced risk of sleep-related accidents.
It provides the patient with a functional buffer against the constant intrusion of their sleep drive. And that translates perfectly to the subjective data we see, correct?
It absolutely does.
Because a statistically significant mean reduction of about 3 points on the Epworth Sleepiness Scale demonstrates that this 4-minute laboratory buffer is actually moving the needle on the patient's perceived quality of life.
Precisely. The Epworth Sleepiness Scale reduction validates the objective laboratory findings. It confirms that the neurochemical support provided by the medication is actively reducing the patient's propensity to fall asleep during standard daily activities.
Activities like reading, watching television, or sitting in a boring meeting. So we have established that the laboratory data shows a functional buffer, and the subjective scales confirm it. But surviving the maintenance of wakefulness test does not mean much if the patient crashes at 4 o'clock in the afternoon during their commute home.
That is a massive clinical hurdle, the afternoon crash.
It is a very common patient complaint we hear in the clinic, that late afternoon slump. How does the data guide us in bridging that late afternoon gap?
Well, the paper highlights specific dosing strategies ranging from 200 to 600 milligrams per day.
And the data from Schwartz and colleagues is particularly illuminating here.
It really is.
When patients took a single 200 milligram dose in the morning, only about 9% could stay awake for at least 20 minutes in the evening.
About 9%. That is incredibly low.
But when taking split doses of 400 or 600 milligrams, about 60% and about 58% of patients, respectively, maintained evening wakefulness.
Those percentages present a stark contrast in clinical outcomes based purely on how the medication dose is distributed throughout the day, rather than just relying on the total daily intake.
I must push back on the aggressive dosing recommendations here, though, based purely on clinical realities.
Fair enough.
We all know that adverse effects for this medication are heavily dose-dependent. The paper mentions headache, nausea, and dry mouth.
They certainly do.
If we push a patient to a split regimen of 600 milligrams a day just to get them through dinner, are we not guaranteeing they will suffer from severe dose-dependent adverse effects, primarily profound insomnia by bedtime?
You are bringing up a very valid concern.
Furthermore, looking closely at the numbers from the Schwartz data, a split dose of 400 milligrams resulted in about 60% of patients maintaining evening wakefulness.
Correct.
But a split dose of 600 milligrams resulted in about 58%. We actually lost efficacy while increasing the dose.
We did.
So why would any clinician push to 600 milligrams when the pharmacological ceiling is clearly established at 400?
That is an exceptional analysis of the data, and it highlights a very real clinical balancing act. You have correctly identified a pharmacological ceiling effect regarding evening wakefulness.
It just does not make sense to push it higher.
Exactly. The drop from about 60% to about 58% strongly suggests that pushing the split dose to 600 milligrams does not yield additional wake-promoting benefits for the evening, but rather introduces complications.
The adverse effects take over.
As you noted, common adverse effects are directly dose-dependent. The highest doses often lead to severe nocturnal sleep disruption.
Which paradoxically increases daytime sleepiness the following day.
Absolutely. This perfectly explains why the efficacy numbers plateau and slightly regress at that 600 milligram mark.
It requires a highly individualized strategic approach. We cannot simply write a prescription for a massive single morning dose and assume the patient's neurochemistry is adequately supported for a 16-hour day.
Because the plasma concentration will inevitably wane.
Exactly. But we also cannot blindly increase the split dose past the point of diminishing returns.
The key for neurologists is to meticulously weigh the absolute necessity of evening alertness against the severe risk of disrupted nocturnal sleep.
It is all about the patient's lifestyle.
You must tailor the split dosing based on the patient's specific occupational and social demands. The data clearly shows that if a patient fails a single morning dose due to severe evening sleepiness, the next logical evidence-based step is a split dosing regimen of 400 milligrams.
That pharmacokinetic reality should guide our prescribing habits before we immediately switch a patient to an entirely different class of medication.
Exactly. And if a patient experiences severe nocturnal insomnia on a split dose, you must adjust the timing of that second dose.
Perhaps moving it from the early afternoon to the late morning.
Or simply reduce the total daily intake. It is a delicate balance.
Well, having thoroughly covered how to maximize modafinil for excessive daytime sleepiness, our discussion must move to the drug's stark pharmacological limitations.
Yes, we need to talk about what it cannot do.
Specifically, we must address its failure to manage the other cardinal symptom of narcolepsy type 1, which is cataplexy.
A critical distinction.
The paper confirms modafinil is a non-amphetamine central nervous system stimulant. It primarily works by binding to dopamine transporters, inhibiting reuptake, and thereby increasing extracellular dopamine levels in the striatum.
And crucially, the data emphasizes that it does not bind to adrenergic or serotonergic receptors.
Because of this highly specific mechanism, it reduces sleepiness without the high abuse potential associated with amphetamines.
Which is fantastic for safety.
But its effect on cataplexy is entirely inconclusive.
The receptor specificity described in the paper is a double-edged sword. It is the medication's greatest strength regarding its favorable safety profile and low abuse potential. But it is simultaneously its most significant clinical limitation regarding comprehensive symptom management for patients with narcolepsy type 1.
I often think of it using this analogy. Using modafinil for a patient whose primary debilitating complaint is frequent cataplectic attacks is like putting premium gas in a car with a broken steering wheel.
That is a brilliant way to frame it.
You are successfully powering the engine to maintain wakefulness, but you still have absolutely zero control over the chassis and the sudden loss of motor tone.
Exactly.
If a patient with narcolepsy type 1 walks into your clinic and their cataplexy is completely uncontrolled, let us say sudden muscle paralysis triggered by laughter, does starting with modafinil make any clinical sense given what we just discussed about its exclusive affinity for dopamine transporters?
From a purely neurochemical perspective, it does not make sense as a monotherapy for that specific complaint. Modafinil is brilliant for restoring wakefulness via dopaminergic pathways in the striatum.
But it leaves the other pathways untouched.
However, the complete lack of adrenergic and serotonergic modulation means it cannot stabilize the motor control pathways involved in cataplexy. We understand that modulating norepinephrine and serotonin is required to suppress cataplectic events.
So polypharmacy is basically inevitable.
Therefore, for narcolepsy type 1, neurologists must anticipate utilizing adjunct therapies. Modafinil elegantly targets the excessive daytime sleepiness, but the underlying motor control instability remains completely unaddressed by a purely dopaminergic agent.
This perfectly illustrates why deeply understanding the mechanism of action is vital for clinical practice, rather than just memorizing a list of approved medications.
You cannot just treat the label, you have to treat the neurochemistry.
You might effectively keep the patient awake with modafinil by inhibiting dopamine reuptake in the striatum, but they will still experience sudden loss of muscle tone unless you add another agent to address the distinct neurochemical deficit causing the cataplexy.
The paper reinforces that modafinil is an excellent, highly targeted therapy, but it is not a comprehensive solution for the entire pathophysiological spectrum of narcolepsy type 1. Neurologists must remain vigilant and utilize combination therapy when managing patients with frequent cataplectic attacks.
Ensuring both the dopaminergic and the adrenergic and serotonergic pathways are adequately modulated.
Absolutely.
Well, before we conclude, we promise to respect your time, so let us review the core takeaways from the paper we have analyzed today.
The practical clinical summary is clear. Modafinil remains a highly reliable, short-term wake-promoting agent that significantly improves both objective and subjective measures of sleepiness.
And regarding the afternoon crash,
For patients struggling with late-day crashes, utilize split dosing of 400 milligrams to maximize evening alertness without breaching the pharmacological ceiling.
which avoids unnecessary adverse effects.
Exactly. However, remember that its efficacy on cataplexy is negligible due to its receptor specificity, and long-term randomized safety data is still surprisingly absent from the modern literature.
Thank you for joining this deep dive.
I will leave you with this. If modafinil so effectively restores wakefulness purely by inhibiting dopamine reuptake in the striatum, yet completely fails to halt the sudden atonia of cataplexy, what does this massive pharmacological disconnect tell us about the separate, complex neuroanatomical networks governing our sleep-wake cycle versus our motor control? And should this prompt us to fundamentally rethink our reliance on monotherapy as a starting point?